It is my most intense pleasure today to introduce our speaker for today's webinar. Dr. Ushma Goradia is the founder and director of Active Karya, which is a clinic based in Bangalore. Her practice focuses on providing comprehensive rehabilitation services for pediatric patients and individuals with neurological conditions. Ushma and I, like Sir just mentioned, we've known each other for a while, so it's very difficult for me to read a very formal, introduction. But her work is so impressive. She has over 35 years of experience in pediatric therapy, ranging all the way from early intervention services to school-based therapy to outpatient centers. Out of these 35 years, she spent 17 years in the United States and has similarly moved back to Bangalore to work with children here now. She has a bachelor's from Mumbai and a master's degree from New York University. She also went ahead and got a doctorate in physical therapy from Rutgers, which is a institution in the US. Around that time, she also got her certification in sensory integration through the University of Southern California. This is a gold standard program that equips therapists with advanced skills in treating sensory processing disorders. Ushma also has previously held board certification as a pediatric specialist through the American Physical Therapy Association. This recognizes her expertise in treating children with complex development and neurological needs. Through active Karya, Ushma continues to make a meaningful impact in the lives of children and adults. And as we again mentioned before, she's a great mentor, to not only me, but a lot of budding therapists, experienced therapists, because it's always great to learn from, her experience. So I welcome Ushma today, and I'm looking forward to learning from her. Thank you.
So, thank you everyone for your kind words. Uh, I am very happy to be here. I am, thankful to the Indian Academy of Cerebral Palsy and specifically to Dr. Mallikarjun and to Vidya for inviting me as a speaker here. And thankful to all the audience who have.
Shows that it's being recorded. Yeah.
Okay, so thank you all for being here this evening for this presentation. And I'm going to dive right into this topic, which is very close to my heart, bridging sensory and motor components in pediatric PT. So we are all pediatric physiotherapists, whoever is interested in this topic and watching this video. But the one thing is very important to bear in mind, that as physiotherapists, as pediatric physiotherapists, we focus more on the motor impairments of the child whom we see. We look at muscle tone, we look at motor control, we look at the various stages of motor development. How does the child go through the stages of rolling, sitting, crawling, standing, walking, and further, if the child still comes to you. However, we have to bear in mind that this motor development that we see is only one side of the whole picture, or it's only one piece of the whole puzzle of childhood development. We have to bear this in mind if we need to get better outcomes. So then what is the other piece? As physiotherapists, we focus on motor. What is the other piece of development? Let's see. So this is a pyramid of learning. It was designed by an occupational therapist, Kathleen Taylor, and a special educator. Many other sites on the internet also credit this pyramid of learning to Williams and Schellenberger. So I give credit to both right now because this pyramid of learning has been very useful to me as a therapist. When I see any child in front of me, regardless of the diagnosis. So if you look at the bottom of the pyramid now, you can see the central nervous system. And then the first layer that you see, the sensory systems, there are 8 sensory systems. And then the next developmental step is the sensory motor development. So we have to understand that the sensory motor development occurs from 0 to 2 years of life, and it is based on the development of the sensory systems. So that is why I say that just looking at one piece, the motor development, is not going to help, because 0 to 2 years is the sensory motor development, upon which then we have perceptual motor development, and then finally we have the academic learning, or for that matter any learning in life. And then we have the activities of daily living, which we focus on, because the whole purpose of therapy is to make the child functional and engage, make them engage in activities of daily living, so that the child can be as independent as possible, as they grow up. And then obviously the behavior. So socially appropriate behavior, age appropriate behavior in the appropriate social context. So mostly when we talk of therapy, any therapy, physiotherapy, occupational therapy, we are aiming for learning, we are aiming for activities of daily living, and we are aiming for behavior. So how do we get to the top of the pyramid? Again, I don't want to, project this idea that this is a step-by-step procedure, but I want to convey to you that the development of the sensory systems is very important, because sensory motor development in the first 2 years of life is very important. And if you only look at one part of the piece, you are not going to get good outcomes. So now, in the previous slide, if you saw, we have 8 sensory systems, and the first step, the proprioception, the tactile, the vestibular, and the interoception, we call them power senses. Interoception has only been started to be recognized lately, very recently, in the last few years, that interoception is very powerful in our path of development, and we have to recognize it when we see a child or when we treat a child. So power senses until now are understood as vestibular, proprioception, and tactile, and now science has added interoception also to that, and that makes a lot of sense. So to us as physiotherapists, as pediatric physiotherapists, why do we want to look at the vestibular, the tactile, the proprioception? And personally, as a sensory motor therapist, I call myself now proudly as a sensory motor therapist, because I deal both with sensory and motor. I also add visual perception, because vision is very powerful. It connects, vision is not processed only by the occipital lobe. The occipital lobe connects to 70 to 75% of the rest of the brain. So there we can understand, how much vision plays a role, and therefore vision perception plays a role. So vision perception is basically, how do you process the visual information that the eyes are seeing? How does the brain process the visual information that the eyes are seeing? And to me, as a therapist, visual perception is also very important. I heavily focus on visual perception besides vestibular, proprioception, and the tactile systems. So we as physiotherapists understand the vestibular system as a system of movement and balance, but there's much more to it. The vestibular system plays a big role in attention, in bilateral coordination, that is using the two sides of the body in function, and emotional regulation. How do you regulate your emotions in a particular context, in a particular situation? And again, this relates to behavior. So, and then there are many other roles also of the vestibular system. But all I want to convey today is the vestibular system is a very powerful system. It has been not given that much importance in rehab, not as much as it deserves in our daily function. Okay. Then next is proprioception. So proprioception, we all know it is, it's a sense of body awareness. It's also a sense of body spatial awareness and force gradation, which is very important. Force gradation means how much force do you use to execute a particular action, whether it is a gross motor action or it is a fine motor activity. But there is a different force for different activities or different tasks that we are supposed to use. So I will just give a very small example of force gradation is that if you pick up a glass filled with water and bring it to your mouth, if you bring it with excessive force, the water is going to spill and not reach to your mouth. Vice versa, if you bring the glass with very little force, you are going to take a lot of time or may never end up bringing it to your mouth for drinking. So that way, if you think about every task we do or every action we do, there is something called graded force that is used, and we call it as force gradation, meaning optimal force for that task in that particular moment. Not too much force, not too little force. So this force gradation is a function of the proprioceptive system. And then touch. Tactile is very, very important because skin is the largest organ of the body, and everything starts with tactile. When a mother holds a baby in their arms, they get tactile input. Tactual exploration or tactile exploration begins early in life. We all know that is, the infant brings their hands to the midline, they bring the hands to mouth. For exploration, they bring their feet to the mouth, which again, this tactile exploration, that is midline, hands in midline, hands to mouth, hands to feet, they all play a big role in body scheme, development of body scheme. That is, how are your body parts arranged in a particular way, and you're aware of it proprioceptively. It also plays a role in motor planning and motor coordination. Again, a important goal in our therapeutic sessions. So, when we talk about visual perception, I said that visual perception is basically the brain understanding or interpreting the visual information that I'm seeing right now in my environment. The brain is processing that. So, midline tracking, eye-hand skills, how does the, how do you reach out for an object? How much do you reach out for an object? Eye-hand coordination. And the most important component is that we visually map the environment, or we visually map the environmental information to our own body, meaning that how far am I from this wall versus the other wall, or how dark it is here and I can't see here, or it is very, very bright and this hurts my eyes. So this way, in many, many ways, visual information becomes very important. Visual perception becomes very important. particularly in future when the child has to attend school, go through reading, writing, visual perception becomes another component added to the vestibular and the proprioception and the tactile. And then not to forget, very, very important is that these systems, the vestibular, the proprioception and the tactile, they relate to weight bearing and weight shifting, something that physiotherapists are very good at when we treat a child. The vestibular system is the system through which many primitive reflexes are mediated through, and therefore we all look for integration of the reflexes. So how well are they integrated? These reflexes are mediated through the vestibular and the proprioceptive system. Sometimes even the tactile comes into play, and therefore these power senses become very crucial to understand. So sensory and motor, as I said earlier at the beginning when I started, we cannot ignore the sensory systems. We have to have a sound sensory system along with the motor development. Why? Because there's a constant feedback loop between sensory and motor. Both these systems work in tandem with each other. Sensations affect your not only motor responses, but also your behavioral and your cognitive responses. So how does this happen? Sensations, if there is a loud noise outside on the street, there's a loud noise, I will immediately get up and go to the window to see what happened. Or behavioral, if I'm feeling very hot or cold, I start complaining easily. Okay. If we are feeling uncomfortable in an environment, we can't think very correctly at that moment. The brain feels cloudy to you. Your emotions feel cloudy to you because the sensations in the room or the sensations that are being processed inside your body and the sensations that you're receiving from the external world are uncomfortable to you, and therefore even it affects your thinking, it may affect your speech, it affects your emotional regulation. I've already mentioned that. So why do physical therapists, physiotherapists have to keep this in mind? Because if we push the child or if we force a child to do things that they are uncomfortable in our treatment sessions, they may heighten the sympathetic nervous system. The child may have increased heart rate, increased respiratory rate. There is basically a stress reaction. The autonomic system gets triggered. And we all know that the sympathetic system is your fight and flight response, and the parasympathetic is your balance and equilibrium, emotional balance and equilibrium. So we don't want to trigger the sympathetic nervous system in our treatment. And if the sensory systems are triggered, if the child is sensorically not feeling comfortable in your session at that moment with that activity, whatever you're doing, then you have to watch the child, whether they have increased heart rate, how are they breathing, why are they crying. Okay, you do not want to trigger a stress response. This is where the sensory systems, having a knowledge of the sensory systems becomes important in our treatment. Why think sensory along with motor? When we look we look at our children, we see children with hemiplegia, we see children with cerebral palsy, spastic diplegia. Nowadays, a lot of children we get with a diagnosis of global developmental delay. That means there are deficits in not only motor, but sensory, cognition, speech, emotional, everything else. We see many preterm babies. We see children with Down syndrome. These are some of the diagnoses that we see. And yes, there are many, but these are the diagnoses that they will be seen in every pediatric physiotherapy clinic. So What is common among most of these diagnoses? Just look at the right column. In hemiplegia, you have unilateral neglect. You may also have a visual neglect. Most of the diagnosis, we have altered muscle tone, we have postural instability, we have balance deficits. The child may not be appropriately be able to use their two sides of the body together, and hand functions. So we have to be mindful about how the child is using hands. Even if you're not working with a fine motor activity, uh, physiotherapists generally think, oh, let's refer the child to an occupational therapist. Yes, you can do so, but you have to be mindful about the hand functions. Also think in treatment, what do we do during tummy time, that is in prone or in sitting? We do weight bearing on the hands, we do weight shifting in various positions. So what happens? Weight bearing on the hands, and therefore you cannot ignore hand functions. We have to be mindful about what the hands are doing, whether the child is able to take weight on the hands, whether the child withdraws the hands, how is the child using his or her hands together or to manipulate objects. You at least have to observe that. We have to remember very importantly that lesions in motor production areas, they also affect the sensory processing areas. Motor cannot go without sensory. Without a sound sensory development, motor responses are poor. Why? Because lesions in one area also affect the other areas directly or indirectly. We see in our clinics and in hospitals that children with neuromotor impairments, they frequently show something called as sensory processing dysfunction or sensory processing differences. And this has to be addressed, or you at least have to be mindful about it. Marsha Stemmer, the reference that I have given here, she has mentioned a lot about sensory impairments in her book. Although her book is only about treating cerebral palsy, but she has given due importance to sensory impairments. So please check out that book if you can. Marsha Stemmer is the author. She is a pediatric physiotherapist. The other important component that we see is lack of movement in our children. Our children do not adequately move due to whatever reasons, due to their conditions, due to their diagnosis, due to their muscle tone, balance. There are so many reasons why our children that we see in the clinic do not move adequately. And lack of movement leads to lack of exploration, leads to lack of sensory processing deficits. Okay, lack of exploration leads to sensory processing deficits. Excuse me. Yeah, movement is the key not only for motor development. When we think about movement as only motor, we also have to think of it as sensory, because vestibular is a sensory organ and movement leads to cognitive as well as social development. So very, very important. When we treat children in our clinics, generally what do you see? If you walk into any physiotherapy clinic, we see children crying. Children, some of the children are crying, some children are happy. But at the first session, when you try to touch the child or test something in the child starts crying. Yes, it has to do with the clinical environment or other factors. But remember that the child may possibly be hyper responsive to the tactile system, and therefore they may be uncomfortable with the therapist. Therefore, we see their behavior of crying, They do not cooperate. And if they are an older child who can at least walk, then they may just walk away from you, or they may withdraw away from you. And if they are crying, or if you're forcing them to do something, remember, you may trigger the sympathetic nervous system, and we don't want that to happen. Changes in position. We put children on the ball. Pediatric physiotherapist, obviously, ball is a important tool, and we love to put the child on the therapy ball in different positions, moving them in different directions. However, some children may be hyper responsive to the vestibular information that they are getting when you are doing your ball therapy. You have to be you have to be mindful about that some children may be fearful of that movement on the ball. Some children may have gravitational insecurity. That means that they may be fearful of leaving their feet from the ground. Even a baby leaving the feet from the ground, or just being disconnected from the ground, may throw them into a fearful mode. So then what do you do? I will talk about that later, but please be very mindful that it can a child can be vestibular hyper responsive, can be fearful of movement, and therefore they can be uncomfortable on the therapy ball or the wobble board or something like that. In that case, you have to work with the child in the mother's lap, because the mother stays or the parent stays with the child 24 hours. So the child will trust, the baby will trust the parent much more than you trying to do something on the ball. And then there can be issues with depth perception. So children who are already walking, who are doing stairs, young children 2 to 3 years old, their parents often have, they want their child to ascend and descend steps. That becomes another goal after the child achieves walking. However, the child may be afraid of descending the steps even beyond the age of 4, even though they have been walking since the past 2 years or something like that. And they may be still fearful of jumping down or descending the steps, or they may not descend the steps in the appropriate alternate pattern beyond the particular age when they are supposed to achieve that milestone. And parents want that goal, but then the child may have issues with depth, something what we call depth perception, particularly when the child is going down, descending steps. Ascending steps would be okay for the child, but descending steps, the child becomes a little fearful or apprehensive, or they hold out, for the parent. They call the parent, and they ask for parental support, or they hold on to a rail and they stick to the rail. So depth perception is very important. And research has shown that children who don't get adequate tummy time by 5 months of age, they are highly likely or possibly may have depth perception issues in future. So this is an important point to bear in mind for physiotherapists. So what are the sensory flags? If you take a child with any diagnosis, check for, as a physiotherapist, check for asymmetrical posture, right? We all do that. When I see a child with asymmetrical posture, besides the asymmetry in the strength or the weakness, one side is weaker versus the other, for me, it also becomes an issue of midline, whether the child can stay in midline, whether the child is in midline to start with in the first place. Balance, fear of movement, stepping, jumping, climbing, I already spoke about. It can be related to depth perception also, that is vision, and it can be related to the vestibular system. Body awareness, body spatial awareness. Body awareness is not only pointing your body parts, so this is my head and this is my leg and these are my hands, But body awareness is how aware is the child about where are they sitting or how are they sitting, where are they standing. Body spatial awareness is whether the child can reach for an object in a particular direction, or if a child is walking and we ask them, go get that toy from the other end of the room, can they walk there independently? Can they perceive that I am here and that toy is in a particular corner of the room? Can I walk there and get back the toy? Many of our children also demonstrate constant head shaking. They demonstrate restlessness and impulsivity. These are all sensory issues related to the vestibular system. Head shaking, restlessness is they are seeking movement. They want movement because humans were made to move, not to sit. And as I already said in my earlier slide, our children do not get adequate movement for whatever reason. So, movement becomes very important if a child is not able to walk, not able to sit independently. Now, we also put the child in the wheelchair and we provide movement. In wheelchairs, we provide movement by sitting the child on the swing, etc., etc. So, there are ways to provide movement to the child, but movement is very necessary. If the child is not using hands, they may be tactile defensive. That means they would withdraw their hands from a toy that you're giving, or if you're offering a handshake, they may withdraw from you. They may not feel tactually comfortable with you. Bilateral coordination, how are they using both sides of the body? Look at their eye contact. And then visual perception, depth perception, something to keep in mind. But always look at their eye contact, whether they can make an eye contact, how long, whether they can sustain with you, with other people in the room. All of this becomes very important. So recognize the sensory issues. Why is it important for pediatric physiotherapists to understand the sensory issues? Why? Because if you understand something, then it is easy for you to recognize the sensory issues, and therefore you can refer out to an OT. If you can't refer out to an OT, you have to look for other options to at least address the sensory issues so that you are providing a holistic intervention and you get better and faster outcomes of therapy. We just cannot focus on one side of the whole development and not get outcomes, whereas the other side is ignored. So, recognizing the sensory issues along with the motor development, get the sensory issues treated, address them, makes you a better therapist. Now, let us look at some of the therapeutic activities from the sensory purge, meaning we all do things like weight bearing in prone, we straddle a bolster, we put the child on a bolster and we do trunk rotation, crossing midline activities. We put the child on a wobble board for balance. We do gait training, we do stair negotiation. These are just a few of the many activities we do, and we have, goals of gait and stair negotiation. Keep in mind that these are not only motor activities. They also bring in vestibular, proprioception, tactile, and the visual systems in. Remember, I spoke about the weight bearing, weight shifting. I spoke about the weight bearing, weight shifting earlier, that the vestibular system deals with weight bearing, weight shifting, the proprioception also. So just don't look at the muscles, just don't look at the muscle tone. Also keep in mind that the sensory systems are also playing an important role when you do your therapeutic activities. So, performance of any movement. We look at motor, but performance of any movement in isolation is not adequate. This paper that came out in the PT journal in 2013, it's been many years now, but it was one of the first papers that came out. It's a descriptive paper, but it gives a lot of good information about how you cannot focus only on motor skills when you are treating children. You have to provide children with something called as grounded perceptual motor experience. Okay, so please read that paper if you can. It is accessible to everybody now because it is very old. Children have to interact during your treatment. Children have to interact not only with objects, with the therapists, or maybe another child in the room while you are doing different activities with a child, such as rolling, crawling, bending, kneeling, kneel walking, etc. So, So only then you will see better outcomes, only then the child will participate better and learning can occur. Make your activities enriching, make your activities meaningful, because if the activity is meaningful, then it will lead to neuroplasticity. Make your activities play-based, fun, and so that the child is motivated to participate. Upgrade your activity in terms of reaching for objects, transporting objects from one side to the other, fixing a puzzle, throwing something at a target, and include movement. Include visual references, that is picture cards, puzzles, many things if you can be creative. Offer also hand materials. I place a lot of importance of offering hand materials, even though as a physiotherapist it may not be a goal to address fine motor activities, but offer a variety of hand materials that are readily available in your environment. You don't have to spend too much money for it, but offer a lot of hand materials, a variety, so that the child receives tactile and proprioceptive input as a part of your therapeutic activity. So remember that pediatric PT is not only about motor, it has multiple domains: motor, sensory, communicational, emotional, and social. Pediatric PT, I believe, is an art. You have to be creative, but it is based on the sound foundation of science. And then think about what to do, how to do, when to do, and why are you doing that particular activity at that particular moment. What are you addressing? Besides a motor, which are the sensory components that are playing a role? And whether you want to refer the child to an OT, will the child benefit from referral to an OT? Please think about that. So these are my references, and um, uh, mostly I look at papers, and there are some very important books like by Barbara Connolly and Montgomery, Marcia Stamer I already mentioned, and then the motor control and the motor motor control and motor learning by Shamwe Cook. So let's look at some of the videos, and then I will quickly end. These are very short videos. I would love to show them here. Yeah, so this is the baby. If you can just observe, the baby is in the mother's lap, and the mother is seated on a therapy ball. Very safely though. The mother is seated on a therapy ball, and the baby is also, I've given a ball to the baby to hold. So just see how they are. So see how the baby is just touching the ball, feeling for the ball, and that visual pattern. He's motivated. He's raking his fingers, and he's getting the movement, he's getting the tactile. Okay, so this was a child with Down syndrome, a very young child. So I'm providing movement. I'm doing sitting balance on the scooter board. I'm providing movement. There's a mirror in front of the child for a visual input, and I'm having the child reach in different directions. So just look at how the motor and the sensory components can be combined in your treatment.
Need to yellow also. Very nice.
Yeah. So this is a 4-year-old girl, a 5-year-old little girl with hemiplegia. And I'm doing a functional activity to address the bilateral coordination. She was very, very tactile, defensive when she came to me. She had her elbow flexed, her wrist flexed, her hands very fisted, the side of the hemiplegia. But after 1 year, we had this function because, besides the motor, even the sensory was adequately addressed. Now, here, again, this is another child who nobody really knew whether he had autism, he had hemiplegia, nobody knows that. But I just provided a holistic treatment.
Down to up, the entire upper body. Full time, full heart. You can have the left hand also.
So basically, that child, not only I put him prone on the ball, that we usually do for many, many children. That is one of the important treatment activities that we do. But I also had some cards, some playing cards laid out, and I'm asking him to pick up, the number of the card or the symbol of that card, so that he has to pick, he has to search in those 7, 8 cards. He has to search with his vision, with his eyes. Where is number 2 card, or where is the card with flowers on it, etc. So here I am bringing in vision perception along with other components that I want to address. This is a child with spastic diplegia. So we are doing rolling in the barrel, which is again a resistance activity for the motor because the barrel is quite heavy. We are doing rolling, but I'm also looking at how I'm also providing body space awareness, that is rolling the barrel from one point to the other, carrying a puzzle piece or a block from one point to the other, and again fixing there. So again, everything comes rolling, body spatial awareness. You also get the core strength. The child is carrying a piece of puzzle in his hand and then going to the other, rolling to the other point and fixing. So again, a fine motor task, a vision perception task. You can address so many components in one activity. I will. So again, this is a young lady who I treated for. She had a traumatic brain injury and her presentation was hemiplegia on one side. And I'm combining NDT and sensory integration over here because I'm doing the weight bearing on her weak side, and I'm asking her to reach with the other side, which is sound, which is less involved. And thereby here I am working on vision perception. I am working on core strength, I'm working on weight bearing. So then multiple systems come into play, the vestibular, the proprioception, vision, multiple systems come into play. And then the last video we'll look at is, yeah, I love teaching through videos because you can learn better when you see an action being done. This is again a child with spastic diplegia, 6-year-old. दूसरा येलो भी रेडी है आपके लिए, येलो भी तो रेडी है आपके लिए। यस यस, चेक कर रहे हो, अच्छा लग रहा है शेप में। ये तो आगे आ गए, थोड़ा पीछे करो। अरे कौन सा कलर उठाया? ग्रीन। और दूसरा देखो कितना सुंदर बॉटल है, कैसा है? ब्राउन और ब्लू। और भी सुंदर है, देखो देखो। So this was a little gist of how I work. The last video that you saw was, where did I go? The last video that you saw was a child with spastic diplegia but had significant weakness on one side versus the other. So I was doing, turning, having picked them up from the back and thereby addressing many, many components at the same time. And then you saw her shaking the bottle, that proprioception, the force gradation. Children love to hold that bottle and shake it and feel it. They love those plastic bottles. I made a whole